forwards. But I've been given this title. A lot of it you'll know already. It's really where we are in 2025 with respect to juxtarenals, what we should be doing with them, and what the guidelines are really. Um, now, whoops, I've got no conflicts of interest. Now, we all know what a juxtarenal aneurysm is. It's something that has a very short neck. It's defined as 10 to 15 millimeters. And really, standard EVARs don't really work and they don't have longevity. And there's a question as to whether we should be putting complex EVARs in or doing open repairs. Um, and the open repair has always been the gold standard. It's got long-term durability. You don't get these things called endo leaks. We're going to talk about a lot of this meeting. And trouble is you have a higher mortality and a higher recovery time. And hence they've developed fenestrated EVARs that are coming in and producing a lot of good for a lot of these patients. But it requires complex planning and long-term lifetime surveillance. And there are tremendous advantages to this technique. The main problem with open is you have a suprarenal clamp and all the problems associated with that. This is eliminated with fenestrated EVAR, and even more so with off-the-shelf devices that are coming along and being used more and more often these days, and stopping that long wait we have for the making of fenestrated devices. There's very little data out there. There's no randomized controlled trials, but there's this UK Compass study, which really came down in favor of endovascular rather than open. But in sick patients with complex disease, open is still probably the preferred option. And if you look at the overall cohorts here, the mortality, the top line, is far less for FEVAR than it is for open. But there are some advantages for FEVAR, particularly if you're female and if you're symptomatic over open. And those are the two groups that people need to concentrate on. And if you look at the data from registries, you'll see that FEVAR has a tremendous advantage with respect to 30-day mortality and perioperative complications. It's a lot better. But if you look at the midterm, there is a crossover. Because if you look at 3.5 or 4 years all-cause mortality, FEVAR is worse. And a lot of that's due to treating patients with poor cardiovascular compromise. And so you put a FEVAR in, they survive, but they die later on. And also the reinterventions are associated with some mortality. So there's a problem there. In the short term, FEVAR is better. In the long term, open is better with respect to mortality. And that's called catch-up mortality. And this is because of the long-term graft failures, the older cohorts, as we've mentioned, and the need for secondary procedures. And remember, if you do an open repair and the patient survives, it's done and dusted. And they never have to come back for any follow-up. You really do help renal function if you don't have to put a suprarenal clamp on. Trouble is, you can get embolization with FEVAR as well, which people don't really talk about very much. You get stent stenoses in the renal arteries, and you can also get contrast nephropathy as well. And endo's so much more expensive. The longer you survive after endo, the more expensive it is. There's the initial cost, there's the follow-up cost. And if you're looking at cost, open dominates if you live for a long time, greater than 5 years. And that's important in some economies. And also there's anxiety. Patients get worried when you have to scan them every 6 months or a year. And if you look at quality of life, you can see that FEVAR is better initially, but then in 1 to 3 years, open takes over, and patients are a lot happier having had the graft done and not having to attend for annual follow-ups. So really, decision making, if you look at all the literature in fit patients, if you've got good anatomy and you're expected to survive, open probably is better. If you're high risk or frail, probably FEVAR is better. And if you've got hostile necks, probably you should have an open as well. And that's reflected in the European guidelines that were published in 2024. We're getting a lot of patient devices now being made specifically for patients, and this is interesting going forwards. It'll be interesting to see how the longevity is for those devices. There's also AI. There's developing specific devices for individuals and testing them and stress testing them beforehand. And again, smart stents and pressure sensors, which again we're going to hear about in this meeting, are going to really change this game, I think, in the future. So in conclusion, ladies and gentlemen, both of these are complementary, but I think you have to be, if you're a modern vascular surgeon, be able to offer both and not just be an endovascular center or not just be an opus center. Choose the right operation for the right patient. But we do have some evidence over the last couple of years that FEVAR is safe in frail and patients who need urgent repair, and those who aren't going to survive a long time because it becomes very costly continuing with the follow-up. And if you want durability in younger patients who are fit and are going to survive, I believe that, and there is evidence that open repair adds that durability and is probably the treatment of choice. I hope that's clear. There's no randomized data, but that's my interpretation of what's out there at the moment. Thank you very much indeed.
So here for the panel. Yeah, great. We'll have all the discussions after the talks. That was fantastic.